Last week in class, we talked a little bit about what maternity nursing was and a little bit about on the care of a laboring patient. So you've been taking care of med-surg patients. So today we're just going to concentrate on the difference on assessments and different things that you need to know to take care of a laboring patient and the things that may affect the birthing process. So some of the things that we're going to look at is true versus false labor, stages of labor, some of the assessments, including cervical exams and fetal heart tones, and then the factors affecting labor. So when somebody goes into delivery, they're always wondering, how is their delivery going to be? Some people have plans that they want to go all without pain medication. Some people may want a little bit of fentanyl or Stadol. Some people are very sure that they want an epidural. Some are scheduled for an induction. Some are scheduled for C-section. But those that are going to deliver vaginally, they may have hopes and dreams, but there's some things that you can plan for: breathing, relaxation techniques, ways to bring the baby down. But there are factors that affect the labor, and some of those are controllable and some of those are not. When we talk about the 5 factors, we always talk about the 5 Ps. And the very first one is the passenger. And when you look at a little tiny newborn, you would never think, oh, this little baby has so much to do with how your birth is going to be or how your labor is going to be. The passageway also has a lot to do with it. Everybody's pelvis is a little bit different. Does the cervix dilate? Powers is how effective are the contractions, or how well are you pushing? The position of the mother to bring the baby down into the birth canal. And then the psychological response. Is the patient, I can do this, I can do this? Is she very positive and working really hard? Or maybe she's given up and like, I can't do this anymore, and she needs a lot of encouragement. So all these things will affect a woman's labor. Let's look a little bit more closely on the passenger. The size of the baby has a lot to do with how that patient's labor is going to be. I can ask each of you, would you rather deliver a 7-pound baby or a 10-pound baby? Yes, the size of the baby and the size of the head has a lot to do with how your labor is going to be. Macrosomia is a large baby. And interesting enough, 50% of diabetics are prone to have a large baby. And we'll talk more about that when we talk about diabetes. But a large baby sometimes cannot fit through the canal. Labor will stop, and the baby's head cannot drop down the birth canal despite having really good contractions. And sometimes those patients end up with C-sections. And the same with the size of the head, especially in proportion to the size of the mom's pelvis. The passenger has a lot to do in how it's presenting in the birth canal. 97% of all babies are presented in a vertex presentation, meaning head down. A lot of women will worry about, oh, is my baby going to be breech? And really, it is a possibility, but only 3% of deliveries or presentations are actually in a breech presentation. Fetal attitude is what the position of the baby's body parts to its body. For instance, and I always call it more of the fetal attitude is more of the position of the baby's chin. Is it tucked down? Because a baby will fit down the birth canal a lot better if it's tucked down, looking down, and coming out, looking down with its chin tucked, kind of like you're going to go for a dive in a swimming pool. That is the smallest diameter for a baby's head to fit out of a birth canal, with its head down and its chin to its chest, just like you're ready for a dive. That's the smallest position. If it's coming out looking up at the ceiling, or if you can turn it around, instead of looking down, it's looking up, and the chin is away, just for a second, put your chin away from your chest and look up, and you can see how that might be a little bit more difficult delivery through the birth canal. The fetal position has a lot to do with it, and that would be whether the baby is looking down or up or sideways. Again, the easiest way for that baby to come out of the birth canal is its chin to its chest looking down. And you can see here that passenger, that we call it fetal attitude. And I always say when a kid has an attitude, its chin goes away from its chest. That's a baby with an attitude. So this position here is the baby's chin is tucked in to its chest and its head is looking down. So it's coming down the birth canal. So actually when it comes out of the birth canal, it's looking down at the floor. This is the best position for the baby to fit down the birth canal. That would be position A. You could see position B that the chin is starting to come up a little bit, and you can see the diameter on the bottom of the head is a little bit larger to try to fit through the birth canal. If you look at position C, sometimes that's even a forehead is down, coming down through the birth canal. And sometimes that is so difficult, C and D. A D is actually a face presentation, that if they can't get the head down, sometimes that's a call for a C-section. But sometimes the doctors can change that position of the baby's head so it's looking like A to get out of the birth canal. But just by looking at C and D, you can see how that would be more of a difficult position to deliver versus position A. Fetal attitude is the relationship of the fetal body to each other. Basically, it's talking about the flexion of the chin. You can see D versus A, the baby with an attitude looking up versus A. So the passenger has a lot to do with how the birth process is going to be. The size of the baby, the size of the head, the position of the baby, the attitude of the baby. And here you can see, again, the attitude. Here's where the baby is flecked with this chin to its chest in A, and the head comes down, versus B, where there's an extension where the chin is not against the chest, and you can see how that's a face presentation, making the delivery much more difficult. So that's a good picture to show you a difference in the attitude of the baby. It has a big influence on how easy that baby is going to be delivered. Looking here, these positions are kind of interesting. When we talk about ROA versus ROT and ROP, basically you can see that there's 3 letters here. And on this particular one where it says ROA versus LOA. And when we talk about the passenger and the position of the baby, on the ROA, the R part just means that if you look at the baby's back, back is on mom's right side. Now, when we're looking at that picture, the baby's back is to our left, but think of that as the mom lying in bed. The baby's back is on mom's right side, so it's right. O stands for so it's kind of where the baby's lying. O stands for what is the presenting part? Well, I just told you 97% of babies are head down, vertex presentation. We also call it occiput. So we talk about ROA versus LOA. We're talking about occiput. You could also have a face presentation, scapula. You can have a frank breech and all others. But in this particular one, you can see ROA with the baby's back on mom's right side, occiput meaning the head's down, and anterior meaning the chin is tucked and it's looking down as it comes out of the birth canal. LOA, you can see that the baby's back is on mom's left side. Occiput is the face is in the birth canal. And A again means that the baby's chin is tucked. Now, I'm going to say this is a lot of times in the hospital, we won't refer to it as ROA or LOA because it really doesn't matter to us really if the back is on mom's right or left side. Most laboring patients are going to be occiput, which is head down, because 97% are. But it does matter if it's anterior for looking down versus you can see in the middle pictures, you can see how it says ROT and LOT. Transverse means the baby is not looking down, it's kind of to the side. And a lot of times as the mom labors, that head will rotate into an anterior position. So it may start out like on the top where it says ROP and LOP, meaning a posterior position, meaning the baby's head is looking up, not down. Then it rotates into a transverse position, and hopefully by the time you deliver, it's in an anterior position looking down. If it does come out in a posterior position, it takes up more room, and a lot of times the baby can't get stuck. So we actually position mom in different positions to try to get that baby to rotate into an anterior position. When you come into the simulation lab, I will show you on a baby. I have a baby that's in a pelvis, and I can show you that, so it makes a little bit more sense. But basically, just know that the first one, ROL, means where the baby is lying, on mom's right side or left side. The middle number, O, is occiput, meaning it's head down first. And anterior is the baby coming out looking down with its chin tucked. Is it posterior where it's looking up, or is it transverse where it's in the process of turning? You could just see that a baby in a longitudinal lie, meaning the head is down, is going to be easier to deliver versus a transverse lie. This baby, unless it turned to be head down, would definitely be a C-section, because that would be almost an impossible delivery or a very difficult delivery, increasing the chances of bad outcomes. So that if the baby had a transverse lie, it would be automatic C-section on that. Also, the position of the baby has a lot to do. Here's a frank breech, meaning the bottom is first. A full breech, and this one is a frank breech where it's, and I'm not going to get picky whether it's a frank or a full breech. Breech just meaning it's not head down. So this would be a bottom first. This is the full breech, and then sometimes we actually get the feet coming down. Regardless, a breech delivery increases the chances of bad outcomes, and the reason being is the head has the largest diameter, so it stretches and it comes out. And then the body kind of comes out. When the head first comes out, the head will be coming out, looking down most of the time. Then it turns to the side, and then one shoulder comes out, then the next, and then the baby just kind of slides out because the head was the biggest diameter. If the bottom comes out first, it's a smaller diameter than the head, so you have the possibility of the head getting stuck, especially with that single footling breech, because you got to get the other foot down, and then you've got to bring the baby down, and there's a chance that the baby's head or something will get stuck. And if it gets stuck in the cervix, just think about it, could decrease oxygen to the baby's brain as well. So a lot of times, if doctors will notice that the baby is breech in ultrasound, will probably, if it's a first-time mom, suggest a C-section to decrease any risk factors. Sometimes if it's not her first, and if it's a frank breech, they may talk about the risks, and sometimes they would deliver vaginally. When I first started working, we really didn't do a whole lot of ultrasound, so we had a lot of unexpected breech deliveries, and the doctors were well trained and really good at delivering them. Nowadays, though, most breech babies are C-sectioned, so sometimes the doctors, are not that comfortable delivering breeches, particularly if there's any chance of a bad outcome. So that was all on how the passenger can affect the labor. It's the size of the baby, the size of the baby's head, the position of the baby, whether it's breech, whether it's got that flexion of the chin with an attitude, and whether it's a posterior baby looking up with it, without the flexion of the chin. So the position of the baby, the size of the baby, they all have a lot to do with the labor process. A baby that's coming out looking up with, in a posterior position may take more time to deliver than somebody's baby who is in the anterior position. Again, as long as that baby's head is down, that baby's head can transition into the pelvis and turn from a posterior to a transverse to an anterior position. And there's a lot of nursing interventions we can do as nurses to facilitate that turn. And the number one thing is whenever a patient comes in labor and she was going to deliver vaginally, particularly if she doesn't want any pain medication, one of the first things I say is never get in bed then. Stay out of bed as much as you can. Walk, get on the labor ball and bounce and roll the hips on the labor ball. Do the hula hoop with your hips as you stand up. Get a dance partner, because all that rotation of standing and doing the hula hoop with your hips, dancing with your partner, a slow dance, even getting in water therapy, all helps facilitate the baby coming down the birth canal and rotating into an anterior position. So we call the importance of that the freedom of movement. And that's why we don't like patients to get epidurals too early, is because we want that baby to get settled into the pelvis in a good position for delivery prior to making them, if they get an epidural, then they're pretty much stuck in bed. Although we do have little tricks up our sleeve to get that baby rotated. And one of that is with a labor ball. The passageway also has a lot to do with how mom's labor is going to go. The pelvis, the size of the pelvis, the shape of the pelvis, and the soft tissues, meaning the cervix and the vaginal and the pelvic floor. We know that the cervix needs to dilate. When a patient first when a patient is pregnant, that cervix is long and thick because we don't want the baby to be born early. About 2 to 3 weeks before that baby is born, the Braxton Hicks continue. The baby comes down the birth canal and thins out that cervix. You'll see on the diagram there, 0% effaced. You can see that that is the cervix and it's nice and thick versus the 100% effaced where it's nice and thin. And 50% is where it's halfway through. That cervix needs to be nice and thin. Once it's thinned out, it's easier to dilate open. And we know that a patient's cervix needs to thin out and dilate to 10 centimeters to get the baby out. When I say 10 centimeters, the patient is 10 centimeters or completely dilated, people will say, do I go up there and measure? No, if you are completely dilated or 10 centimeters, there basically is no cervix around the baby's head. The baby's head is just coming down the birth canal. 1 centimeter is like if you check the cervix and when you put your finger in, it's maybe like feels like a little dimple. 3 centimeters, you could fit a couple fingers in there, 5, 6, and you can see as it goes on. Again, when you come into simulation, we'll bring that a little bit more alive because I have a box in which you can actually practice vaginal exams, so it's kind of fun. Again, cervical dilatation, just kind of an imagery thing. If a cervix that is 1 centimeter would feel like maybe if you tried to get your finger through a Cheerio. 3 centimeters would be the size of a slice of a banana, and you can probably fit 2 fingers in. A Ritz cracker would be about 4 centimeters, and you can probably maybe fit 3 fingers in there, maybe with a little bit of room. Soda can, 7 centimeters, and a full-size bagel would be about 10 centimeters diameter to get the baby out. Again, that cervix is very stretchy. If it does not dilate, and there are some people who just do not dilate, that cervix doesn't want to dilate, then that would mean that if it doesn't dilate to 10 centimeters, that's probably going to end up in a C-section, or else you might rip the cervix or something else. So it's very important for that cervix to dilate. Powers. You need contractions to bring the baby down, which actually causes the cervix to open up as well. So there's 2 types of powers. One is the primary force, or the involuntary contraction, or involuntary forces, which is the contractions. A patient has no control. She can't say stop contractions, start contractions. It's just that primary force of the body forcing the baby out. The secondary force is more of a voluntary, and it's the pushing. I can say this, that if the patient does not have an epidural, and once that baby's down and she's completely dilated, she has this urge to push this baby out, and it's uncontrollable urge. With the epidurals, though, sometimes that urge is maybe not present or not as strong of an urge, and so sometimes we have to coach that patient to push the baby out and help her push. A patient who does not have an epidural will just go ah, and push that baby out. They do not need much coaching, but it is a noisy process, and it's important because that's that open epiglottis. Sometimes in the hospital, you'll hear us say, okay, hold your breath and push. Evidence-based practice says it's probably not best to hold your breath when you're pushing, but a lot of nurses still will go with that. But even when they push, just say push it. They can make noise or whatever, because that would be an open epiglottis, which actually gives more force to get the baby out. So again, a lot of times if a patient is pushing, that's pretty much one-on-one as a nurse. If she's got an epidural, somebody's going to have to help hold her legs because her legs will be numb. And sometimes we even have to tell her when she's contracting because she does not feel her contractions with the epidural. So it takes a little bit more nursing care as far as coaching goes to get that baby delivered. Pushing can take anywhere from 20 minutes to over 2 hours on a PRIMEP, meaning it's her first baby, and probably a little bit less time if it's her second baby, of course, depending on all the other factors, such as the position of the baby and, is the patient dilating? I will say this too, is a lot of times we encourage our patients to learn Kegel exercise and to do Kegel exercises. And a lot of you know what those are. And it's kind of like when a woman goes to the bathroom and she stops the flow of urine. That is what a Kegel is, and it's an exercise. We do not encourage women to do Kegel exercises while they're urinating, but when they're not, to do that same kind of contraction, like with the pelvic floor. What it does is it strengthens the pelvic floor, and what actually helps rotate the baby and actually push the baby out. So a lot of times they will say women who do Kegels or do a lot of yoga have strong pelvic floor muscles, and it eases with getting the baby out of the birth canal as well. Again, position has a lot to do with how your labor is going to go, because the positioning of the labor is going to bring the baby down into the birth canal and also rotate it into a good position. We're hoping to get it from a posterior to a transverse to an anterior if it isn't already there. Some of these positions you can see on the left-hand side, standing up helps brings the baby down into the pelvis by the force of gravity. That head, that knee and elbow position is very useful because the baby kind of hangs and has more room to rotate if it needs to rotate into a anterior position. We can also do that with the baby hanging with the use of the labor balls, or just a patient leaning over. And you could see that the coach, the partner there, is rubbing the patient's back. When women go into labor, there's a lot of pressure on the back. A lot of women, particularly if that baby is looking up, it puts more pressure on the back. She's going to have more back labor. And so we do a lot of massage therapy and acupressure to help women get through labor. On the right, you can see all the different things. There's the walking, there's the sitting up, because you still have gravity if you're sitting up. You can see the hands and knee position, which is really good for that baby to hang and rotate. How useful the partner is, maybe in slow dancing or helping her squat, rubbing her back. We can also put a patient up in stirrups. We can get dad behind the patient. Anybody watch Grey's Anatomy? They have some really good pictures of, I can't remember who was helping who deliver. I think it was George helping Miranda Bailey deliver. He popped up on the bed and sat behind her. And then Miranda did that later on, and I forget who it was for, but it's kind of interesting. And some of these medical shows, they actually do show evidence-based practice. Sideline position is always good. Squatting, we have the squat bar, which you can see on the bottom right hand for the squatting position, and that would ease in pushing. Or just bring the baby down. The last P that has something to do with the how your delivery will go is the psychological response. Number one is do you have a good support system? Evidence-based practice tells us that a patient who comes in and has a good support system, her experience will be, she will rate her experience as a good experience much higher. We know the importance of that support system, and as much as we like to think that we're the most important support for the patient, it's not, it's the partner she brings in. Therefore, we always bring that partner in. I'll have the partner, I'll say, why don't you rub her back or help her breathe to get through this. In the beginning of labor, a lot of times we just don't want them to hold their breath, so we have them take a deep breath in and hold it and let it out. Deep breath in, hold it, let it out. As she progresses, we may go into more of a paced pattern, which is a Whenever she's pushing, we have her take a couple cleansing breaths, a deep breath in through her nose and out, and another one in, and then we'll have her start pushing and bearing down. So we do use a lot of breathing and relaxation techniques, massage, music, all that. And that's where the support person comes in. He may have music loaded that she likes, aromatherapy, bringing in, we have it in the hospitals, but a lot of times I encourage in childbirth education for the support person to bring in and give her some aromatherapy. So all kinds of support is very important. We do know that any past experiences, if they're good, it would help her experience. But if sometimes people have really traumatic experiences, it could even be a rape victim. It could be an abuse situation or just a traumatic delivery. And we have to help her work through those past experiences to help her through the labor. Pain tolerance and coping abilities has a lot to do with how a patient's going to handle labor. Some people come in and say, oh, I'm going to do this all natural. I tolerate pain really well. And I look, and she's never had surgery, never had any broken bones. Really, she probably hasn't experienced much of pain. And this will kind of be an eye-opening experience for her. And then it may depend on her coping abilities, as how well she can cope with it. Has she come prepared from childbirth education classes? Does she know breathing, relaxation? Does she know the importance of the breath, different positioning, massaging? And even if she hasn't had childbirth education classes, we as a nurse can help the support person and the patient cope with the pain in a very positive way. Culture has a lot to do with the psychological response. Sometimes there are cultures that are very quiet and you can never really tell. A lot of times I can tell so much by looking at a patient on how much pain they're in, probably where they're at in labor. Asians tend to hide that pain a little bit more. They're very quiet. There are some cultures that are a little bit more loud. The Hispanic sometimes is very, oh my gosh, and it's not a bad thing. It's a good thing, but they're just maybe a little bit more verbal and vocal. Emotional readiness. I mean, with a 15-year-old versus a 30-year-old, are they ready? And those are generalizations, because I've had some teenagers come in and maybe they're the oldest of 6 siblings that they helped raise. And culture-wise, a lot of the high times, maybe their mother delivered at a young age, their grandmother did. So they may be emotionally ready. And I've seen some 35-year-olds, you think they should be, but they're definitely not. So emotional readiness just is emotionally, are they ready for this experience? Are they ready for even parenting? And then the self-confidence, do they come in with an attitude, I can do this? Or are they coming in with an attitude like, oh, no, I can't do this? And really that self-confidence is what we really try to build in childbirth education classes, letting them know that, yes, they can do it. And here's some things that you can do to help you through this process, which is the breathe-in, the relaxation, water therapy, get in the tub. A lot of our hospitals have tubs with whirlpools. Home deliveries, they actually bring in like a pool and they can deliver in the water, because if you think about it, just taking a bath is so relaxing. So we encourage them to do that. We encourage dancing moves and getting on the labor balls and all kinds of things to build up their confidence so that they know that they can do this experience, particularly with good support. So those are the 5 P's that will affect somebody's labor. Again, you have the passenger, the size of the baby, the position, the attitude of the baby. You have the passageway, the size of the hips. A lot of times too, the hips, whether the hip structure is flat or if it's round. The gynecoid is a round-shaped hip, which the majority of women, over 50% of women, have a round-shaped outlet to their pelvis. But there are a few women that have a very flat pelvis, and a lot of times you can't tell by just looking on the exterior. It's the interior, the outlet, that we can't see, but that may affect the birth, and that's part of the passageway as well. And then you've got the powers and the psychological response. Those 5 things will affect how a labor goes. And we already talked a little bit about the stages of labor, but we talked about the first stage of labor is ovidilating, where you have to go from 0 to 10 centimeters, and how a couple weeks before delivery, those Braxton Hicks are thinning the cervix and getting it ready to dilate. A lot of times when they come in and they're like, oh, I think I'm in labor. Oh, honey, I'm getting a contraction, and they're talking to you and they're smiling and they're excited, but they still can text maybe and talk to you. They're in the early phases of labor, meaning they're probably maybe 3 centimeters, maybe 4 centimeters, but still in the early where they still are excited and they can still talk through their contractions. Once they hit active, they get a little bit more worried and concerned, like, oh my gosh, how much worse is this going to get? I don't know, I mean, they start getting worried. You know what I mean? How, about how much longer is this going to be? And that's usually when they're around 6 centimeters. It gets a little bit more tough. They are really focused in on their contractions. And that's where the support system comes in handy. A lot of people will ask, how many people are best to bring into the labor room to help me through this experience? Well, you have a nurse. They really say most evidence-based practice or literature will say about 2 people. And I think that's depends on the person, the culture, because I've had some Hispanic families that they want their mother and their grandmother there, and they're not doing much other than sitting there, maybe knitting or whatever, but their presence is so important to the patient. But we do know literature says 2 people, because sometimes if you have too many people, then you have somebody who's really helping them breathe and relax, but you have a couple people in the background that are laughing and talking and maybe texting, which is very annoying to somebody who's in active labor or transition. Transition is when you're about 8 to 10 centimeters. A patient will get a little anxious. They may get a little hot. They may even throw up. They may get a little shaky. They're transitioning into the second stage of labor, which is the pushing. And that's transition is usually when they're about 8 to 10 centimeters. The cervix is pretty thinned out. The baby's coming down the birth canal. And they're getting ready for the second stage. And the second stage is all the pushing. The first stage can take, just to dilate, can take 12 to 16 hours. Pushing takes anywhere on an average for a first-time mom, 20 minutes to over 2 hours. Some patients just push a couple pushes and the baby's out. But it's all the pushing. And again, I would say from transition to pushing, those patients are pretty much one-on-one, requiring a lot of support. Once that baby is pushed out, and the doctor will be there for actually the delivery part. Once the baby is out and on a delivery, when the baby is being delivered, the standard is having 2 nurses that are neonatal resuscitation certified to be in there in case the baby needs to be resuscitated. Once the patient is delivered, I can guarantee you everybody in the room, there's a little bit of anxiety. What's the baby going to come out doing? Does the baby come out crying and screaming and pinking up and moving? And if it does, it's like, oh my gosh, this baby is transitioning well. Sometimes though, the baby comes out limp, not crying and not pinking up. And that's when we have to do resuscitation, and that's what the 2 nurses are there for. The majority of babies transition into the extrauterine environment just fine, and therefore, usually 1 nurse will assist with the baby, making sure the baby's doing okay, and 1 patient will remain with mom, making sure that mom is doing okay. You are currently the only person in this conference. And so once the baby is pushed out, the game isn't over yet. This whole process is not over, because now the patient has to deliver the placenta. So the placenta usually takes anywhere from 5 to 20 minutes. Usually we shouldn't be pushing on the cord or anything. The patient, the contractions, and the uterus itself will expel the placenta. There are some cases where the placenta gets stuck or attached to the uterine wall, which may cause some emergency procedures, and maybe even for the doctor to go in and get the placenta, or sometimes surgery. We'll talk more about those when we talk about high risk, but in most cases, and what happens in those 5 to 20 minutes is the cord kind of extends, and then there's a little gush of blood, and then out comes the placenta. The doctor will inspect the placenta to make sure that it all came out, because if any piece of that placenta is retained or remains inside, the patient will continue to hemorrhage and bleed and could lose a lot of blood, which could cause anemia or hypovolemic shock. So the doctor will inspect that placenta. Once the placenta is over, he will order Pitocin. Pitocin is the man-made drug of the same hormone that the mom is making to contract. And why we want that uterus to contract, it will contract on its own, but we know this is when most women will hemorrhage. And what we know that is if we give them Pitocin, even large amounts of Pitocin, it doesn't hurt those moms that won't hemorrhage, but it may prevent people from bleeding too much or hemorrhage. So once that placenta is out, the nurse will begin a piggyback solution of Pitocin. And it's usually got about 30 millunits of Pitocin, 30 units of Pitocin in the bag. And we usually will give about 150 cc bolus of a 500 bag with Pitocin in it. And then we'll probably adjust the rate to about 150 an hour. Every hospital is a little bit different. Sometimes Banner will give 2 bags of Pitocin just to make sure that she's not going to hemorrhage. Again, there are some women who don't, but some that do. We know it's one of the biggest things that we're watching out for as far as risk goes, and we want to prevent any hemorrhage, and so we do give that Pitocin. So now the placenta is out. The doctor has inspected it. We have already probably asked the patient if she wants the placenta to take home. Some people will have a midwife dry it up and make capsules, which supposedly helps with postpartum depression. That's fine if they do that. There's not enough evidence that supports that it will do that, but sometimes if that's what the patient wants and believes in, they can do that. Some cultures, the Navajo and some others, would bury the placenta for cultural and religious reasons, and if they want to do that. If they are using that placenta for anything, we need to put it on ice and so that they can take it home. Once that placenta's out, we immediately, that baby, if the baby came out crying and screaming and everything else, that baby goes straight to mom's chest, and it's skin-to-skin contact. There's no bra, there's no gown, it's skin-to-skin contact. We dry the baby off. The doctor will cut the cord once the cord quits pulsating, or A1 standards is at least 30 seconds after delivery. Usually by then it stops pulsating, so most of that blood does get to the baby. The cord will be cut. The baby will go skin-to-skin contact. Of course, we clamp the cord as well. And the baby will go for skin-to-skin contact. The mom then is like, oh my gosh, my baby. And she's examining the baby, bonding with the baby immediately, and we encourage that. We keep mom and baby bonded, skin-to-skin contact, at least the first hour of life. We begin breastfeeding within the first hour of life if she is. We can weigh, measure, and we do have medications to give to the baby right after delivery, which is usually on that hour mark. But we can take vital signs. We can assess baby's heart rate and lungs and everything else with baby on mom, because we want to promote that bonding with that skin-to-skin contact, keeping mom and baby together. That baby should never leave mom for any reason unless there's a medical reason, because that bonding is so important for that stage 4 recovery. In addition to that, we know that this is when most moms may hemorrhage, and so we watch them very, very closely. We check them every 15 minutes. We do a fundal check, or we can feel the uterus, and the uterus right after delivery can be felt right around the umbilicus area. So we check and make sure that it's nice and firm, because if it's nice and firm, it's contracting. If it's contracting, it's constricting the blood vessels and preventing bleeding. So we check to make sure that the uterus is nice and firm and it's right around the umbilicus, and that it's not boggy and everything else. We also check vital signs to make sure that the blood pressure and everything else is stable. We check the amount of bleeding every 15 minutes for the 2 hours of recovery. Once she's recovered and she's stable, if she's had an epidural, she's able to probably move her toes, bend her knees, and actually lift her hips off the bed. We make sure that they empty their bladder, the uterus is nice and firm. Once she's stable, then we will transfer her to the postpartum floor or couplet. The reason we watch them for 2 hours is because this is when most things can happen. And it's a one-on-one recovery, versus once they go to postpartum, that postpartum nurse will have 4 moms and 4 babies. So she is not going to be watching them as closely as we do in that first 2 hours. So we must make sure that they are stable by the time we transfer them to the postpartum floor. So those are the 4 stages of labor. Again, in that first stage, which is all the cervical dilatation. You can see the happy face. They're excited in the latent phase. They're a little worried, but they're excited. In the active phase, they're getting a little bit more serious. They're like not liking it so much. In transition, which is the last phases you'll see, where it's like, oh my God, I can't do this. And sometimes they throw up and sometimes they get shaky. It's a very difficult phase where they need a lot of support. The second stage is all the pushing. It ends with delivery. The third stage is the placental delivery. And the fourth stage is the first 4 hours or 2 to 4 hours after delivery, depending on the facility as far as how long you keep them in recovery room. How do we know if a patient is actually in true labor versus false labor? She comes and most facilities will have a triage area. The triage is like the ER for pregnant women. They come in if they're bleeding. They come in if they think their water broke, if they think they're in labor, if they've been in a motor vehicle accident, or they have high blood pressure, or they just don't feel good and the doctor's office is closed. That's what triage is for. But the majority of the patients we see to see if they're in true labor or false labor, or to see if their bag of water has broken. True labor is contractions that are regular, getting stronger, and nothing the patient can do to stop them. And what those contractions are doing is they're dilating the cervix and bringing the baby's head down the birth canal. So no matter what, those contractions are coming, they're getting closer, stronger together, and good labor pattern is about 2 to 3 minutes apart. But the important thing is those contractions are actually dilating the cervix. Some people's water breaks, but they're not contracting, and their cervix isn't dilating. They still come into the hospital because once that bag of water is broken, the chance of infection getting to the baby is greater, but it doesn't necessarily mean they're in labor. We may have to give them some of that drug that we talked about, Pitocin, that causes the woman to contract. The difference when we give Pitocin to induce labor versus postpartum is we give very, very small. We start at 1 to 2 milliunits per minute, which is like 1 milliliter, an hour or whatever. It's very small amounts because everybody reacts to it different. But what we're trying to do is just to bring on those contractions and kick a woman into labor, versus that Pitocin we give after the baby is a lot different. We can give more Pitocin because there's not a baby inside that we're worried about, because we don't want to put too much stress on the baby with too many contractions. So sometimes they come in with the bag of water broken. They're not necessarily in labor, but we may induce them. False labor is just Braxton Hicks contractions. They may be irregular. They may stop if you lay down. They're maybe inconsistent. The fetuses may not really engage. And the most important thing is they really aren't causing cervical dilatation. And even if they lie down, it may make the labor stop. So that's true versus false labor. Once we've identified that woman is in true labor, they go out of triage into labor and deliver to deliver. Once they deliver and we recover them for a couple of hours, they go into couplet care or postpartum. That's the flow of our department. When we talk about rupture of membranes, it just means the bag of water has broken, BOW, bag of waters, ROM, rupture of membranes, SROM, spontaneous rupture of membranes, where it just broke on its own, like all the TV shows. Oh, the water broke, the baby delivers, which is not really how it happens. Most of the time, the water doesn't break until the woman is in very active or transition. I even had a patient deliver with a bag of water intact. Once it came out, the water broke and I got all wet. But yeah, once the water breaks, though, we need to do a good assessment. The first thing I want to make sure is, did the baby tolerate the water breaking? Because sometimes if the baby's head is not well engaged, that cord may prolapse down, and then the baby's head goes down on the cord and causes occlusion of the blood flow to the baby. So I need to check baby by looking at the fetal heart tones, making sure the heart tones are good. In addition to that, because that's the most important assessment, is to assess the fetal heart tones, so that make sure that cord didn't prolapse. But in addition to that, I need to chart COAT, or I like to say TACO. It's the same acronym, just a different order. But what I'm assessing is the color of fluid. Normal amniotic fluid should be clear. If it's meconium stained, that means you have a bowel movement. It could be a little bit under stress, and that would cause the fluid to be yellowish to green. Sometimes there's this, that the fluid will look like a thick green pea soup. And there we take precautions because when the baby comes out, if it got that into the lungs, it could cause respiratory distress. So we really need to know whether at time of delivery, if that bag of waters is clear or what color it is. We check for odor. If it has an odor, it could mean infection. The amount of amniotic fluid, was it a huge gush? Was it like dripping off the bed? Too much amniotic fluid? Normally there's going to be a little puddle. Sometimes it's a slower leak and you may get more later on. And most important too is the time of rupture. What time did that bag of water break? And remember, when that water breaks, we think infection. And remember, I first talked at the first lecture on maternity nursing that the 3 leading causes of mortality for our women is infection, and it's also hemorrhage, and also hypertensive disorders. So here we go into infection. We put the time because we know 24 hours from the time that water broke, the woman's chances of infection increase. And so once that water's broken, we actually do temps more frequently on mom. If her water's not broken, she's got no risk factor. Sometimes we'll take a temp every 4 hours, but once that water's broken, we're going to be doing it every hour. So that's what we chart, is pretty much those assessments. The most priority one would always be as how well baby tolerated the bag of water breaking. Did the cord prolapse? What are the fetal heart tones? Sometimes the woman will come in and say that she leaked a little bit of fluid. She's not sure if her bag of water broke and I don't see any fluid. So I'll put her up in the stirrups or just have her open her legs. And for women who have had pap smears, it's kind of the same thing. We put the sterile speculum in where we kind of can look inside. I can see the cervix with a light source. I'll ask her to cough, and I'm looking for amniotic fluid coming out of the cervix. I swab with a huge Q-tip type thing. I will swab any fluid that I see, put it on a microscope slide, and then look under the microscope. And we call that a Fern test because when amniotic fluid dries, it has a Fern type pattern, as you can see on the slide on the right side, Fern-like patterns. And that would be a positive. That means her bag of water has broken. It would not look like that. If it did not, it would not Fern. A trained nurse does this, and it's about probably, if a nurse knows what she's doing, about 86% reliable. Sometimes if we're still not sure, we can use an AmniSure test, which is on the bottom left of your screen. And that we take the swab and we get the fluid and we put it in the vial and we swirl it, and then we put the little strip into the vial where the fluid is. 2 lines is a positive, means it's ruptured, and 1 line is a negative. This is supposed to be about 99% accurate, but most people, we can tell if their water is broken, and we can do a simple Fern test because we see the pile, we can tell it's the amniotic fluid. Plus, a Fern test doesn't cost much, which is an AmniSure is more expensive, but if a doctor orders it, we would do it. It's a little more accurate. In case we're not sure, we may do those amnio tests. Sometimes when a woman delivers, sometimes that she may tear a little bit. When I first started nursing, doctors would actually cut the perineum area, and we would call that an episiotomy, and he would cut to give more room for the baby's head to come down. And the logic back then was that a clean cut by the doctors doing it with scissors would heal better and she would tear less. Evidence-based practice today does not support that. They say that it would actually be better if a woman tore a little bit because she might tear less and it doesn't affect the healing process. So when I first started out, I saw doctors doing episiotomies where the incision was made into the perineum to enlarge the vaginal or cervical opening. It was more common in the US and Canada than Europe. And they say because more midwives delivered in Europe and they were less likely to use episiotomies. So it's less common with midwives than OBGYNs. I will say this for the sake of OBGYNs, though, is that, midwives in the United States deliver, and when I first started, were delivering more of the lower risk patients, and they still do. And the OBGYNs were delivering higher risk. But the point is that evidence-based practice now does not support that episiotomies are always in the best interest of the patient. Therefore, we're seeing less and less episiotomies, but the woman still may tear a little bit. Now, the extent of an episiotomy or laceration can go from a first degree to a fourth degree. The first degree is just a little bit of skin, but if they go all the way through the rectal wall, that's the fourth degree, and that is a major. That almost takes a lot as long to repair as a C-section. We kind of call it a vaginal C-section. The thing that it alerts us to as nurses is that she's going to have more perineal pain. She'll need ice on her bottom for the first 24 hours, which we do on all patients, but particularly on those with any kind of tears or repair work on the perineum. You may need, we'll talk a little bit more when we talk about postpartum, some of the things that we can do to relieve the discomforts of repair work on the perineum. Just know, though, that it can be either an incision made by the physician, which is an episiotomy, or laceration or a tear made by the birthing process of the head coming through the canal. When we talk about a birth, there's all different kinds of models of birth. On the left of your screen, you see the medical model. And if you were going to clinical, that would be the majority of what you would see. Meaning it's more of a medical model. And when medical models is we look at, when we talk about a medical model, we talk more about that there's a diagnosis, that there's a problem. And really when we think about birth, it's a normal natural event. It's not a disease or anything, but somehow we tend to make it more of a medical model with the use of IVs and epidurals and forceps and all kinds of stuff. So that's the medical model. But a different model that a lot of us may not see if we if we have not seen it would be like a home birth in water. That's a different model of birth. Another model wives in the hospital. They have little rooms that are really homey, those types of things naturally. There's also C-section birth, and we talked about 31, anywhere from 30 to 32%, depending where you are in the United States. We're trying to decrease the amount of C-sections today, but still a majority of our patients have a C-section, and that's a total different model of birth. We still encourage the bonding and the staying together and everything else, but it is a surgery that a patient needs to recover from. Sometimes the baby needs to be turned, like if it's in a posterior and we want it into an anterior position, or it just needs a little bit of a tug to come out. You can use the vacuum extraction, which is on the type right, or the bottom left is the forceps to kind of guide the baby out. Doctors will not yank or pull. They just want to kind of gently guide them, glide the baby out if it's possible to prevent C-sections or to help the mom out a little bit. I guarantee you a doctor or midwife would not use either the forceps or the vacuum extraction unless it's medically necessary for mom. And then the little baby on the bottom is, I'm a VBAC baby, meaning some babies are vaginal birth after a cesarean. The mom has a trial of labor after a C-section to see if she can do it. And if it's successful, it's called a VBAC, a vaginal birth after delivery. So there's all different types of birth. To me, if a patient comes in and she wants to have a water birth at home, that's great. I mean, of course, if I'm in the hospital, I wouldn't do it there. But if she wants that, I would highly encourage it. Just give her the benefits and risks. And if she fits that model and she's able to, that's great. If she wants to do it at a birthing center or at a hospital, women need to know their choice. They need to know their risk factors, benefits and risks, and make choices that is best for them and their family. Care management of a patient then requires a full assessment. When a patient first comes in, we have their prenatal records. We look at the prenatal records. Labs have been drawn during their prenatal care. Labs mean all STIs. We check their H&H during their prenatal record, their blood type. All kinds of blood work is done. We have that because the doctors send it to us in the hospital. In addition to that, the medical record will tell us that the baby's head's down on ultrasound, where the placenta is, if there's been any problems. When I admit a patient, about 30 minutes to get all prenatal record into her electric medical record at the hospital. Prenatal data gives us a lot of information how the baby's presenting, if it's head first or if it's breech, all kinds of stuff. We interview the patient. We want to find out if there's any psychosocial cultural or spiritual aspects that we need to be aware of. What is her plan for delivery? Does she plan to use an epidural, whatever? And we need to collect all that data. We do a physical assessment. We get her vital signs. We look at her vital signs. We assess contractions. We assess fetal heart tones. We can do a Leopold maneuver, which there's one in your Walter Kluwer's. There's a little assessment there where you can actually, when a patient comes in, I can feel her abdomen to see where the back of the baby is. I can feel where the body parts are, and I can tell if they're ROA or LOA. I can tell if their rear end is at the top and the head is really engaged on the bottom, because there's that round, hard object in the pelvis area. That would be a Leopold maneuver. Of course, the fetal heart tones, contractions, and vital signs, all that is part of the care management and ongoing with our patient. When a patient first comes in, all our patients, when they come in, will draw a CBC. We need to know what their H&H is on admission. We'll check it the next day after they deliver to make sure that it's adequate. We also need to know what the platelets are. Platelets be over 100,000. If they're low, we want to know why. We will do a type-in screen to see their blood type and their RH status. Really important lab there, because with hemorrhage being our #1 risk factor, we want to make sure that we have blood readily available. If the RPR is done in the state of Arizona because there's a rise in syphilis, and so we do the RPR to check for syphilis. It's done during their prenatal, but we also want to make sure at the time of delivery that is a negative status. Again, sometimes we have to assess whether the bag of water broke or the amniotic fluid. UA is just uterine assessment. At high risk as well. Also need to check them for group B. To make a difference in someone's life, you don't have to be brilliant, rich, beautiful, or perfect. You just have to care. By caring, we make sure our patient is treated with ice chips or sips of clear fluid, depending on the doctor's order. All our patients, at least we have an IV line, whether it's a saline lock or an IV. Sometimes we hydrate through the IV. We make sure that we keep their bladders empty. When the bladder is empty, more room for the baby to drop that down into the birth canal. So we keep them voiding. We call it burp our patients, keep them breathing and relaxed, and keep them urinating, keep them relaxed, and also position them frequently. And I have another slide on that, but keep them up to the, make sure they keep their bladder empty. If they have an epidural, we have to check their bladder every couple of hours and straight cath them during labor. There are a few times that we may need to put a Foley in, although evidence-based practice says straight cath during labor is better. It decreases the trauma and the chances of infection than the Foley catheter does as well. Bowel elimination. Most women are afraid when they come in that when they start pushing, they're going to have a bowel movement. And I would say no big deal, because when a lot of people have a little bit of diarrhea or empty bowels before they go into labor, but remember, when that baby's head is coming out of the birth canal, whatever in the rectum is going to come out as well. We just clean it up real quick and act as if nothing had happened. We keep our patients ambulating and position them frequently, again, to bring the baby down into the birth canal and at a good position with its head down in an anterior position with its chin flexed. And we provide supportive care, which includes breathing, relaxation, assisting them to do water therapy, labor balls, aromatherapy, and there's a ton of other non-pharmacological supportive care that we can do that we have in another PowerPoint. I always say to my support people, I always say to nurses, but particularly patients too, always use your brain. Meaning, a lot of times people will go to the doctor's office and the doctor will say about a pill or whatever, and they don't know what questions to ask. And I always say, just think of brain when you don't know what questions to ask. A doctor may come in and maybe patient has told the spouse or the support person, I do not want my bag of waters broken. I do not want my bag of waters broken. And then the doctor comes in and says, I'm going to break your bag of water. And the patient looks at her support system, and the support system's like, I don't know what. And I always say, use your brain. Just ask, what are the benefits of breaking the bag of water? And the doctor may say the benefits are the person's tired, it'll speed things up a little bit, those types of things. Well, what are the risks? Well, the risks are the head's not engaged. There might be a prolapsed cord or whatever. But the doctor would never do it if there's some risks. But look at the benefits. What are the risks? And is there anything else you could do? Because if the point of breaking the bag of water is to speed up labor, well, can you ask to go maybe in the bathtub and go walking or do some, hula hoops or get on the ball, because those also will speed up labor. And then what is your intuition saying? What is your inner core saying? Is it saying, no, I don't want my water broken? I think or is it maybe not now, but maybe later, try me in 2 hours. I'm going to get up, I'm going to go walking, I'm going to get in the tub. And if I haven't progressed in labor, then you may break it to speed things up. Or you can say, no, not now. You can always say, maybe you can even say never. But sometimes you have choices. I tell patients that we do the best to honor their wishes, but if ever, safety always comes first. So if ever it's a safety issue, then we will do our best for the number one outcome of the day, which is healthy baby, healthy mom is our number one goal. And then to get there, you tell me. But if it's going to compromise our one goal we've decided together, healthy mom, safety always comes first. It is our job to keep them safe. And when they know that, it makes a difference to them. So, part of care, keep your patient breathing, urinating to keep that bladder empty, keep them and position them frequently. Just look at this and from your readings and looking at this, if you have any questions, you can them on to your next lecture and clarify any muddy areas. I think sometimes it's hard for people to understand when I talk about the position of the baby, the anterior. I think once you come into the simulation room, models that I have of the fetus and the pelvis and stuff, that you'll get a better idea of that as well. Have a great day.